for this exam. So my name is Dr. Sufia Khan. I work as a consultant dermatologist in Peshawar, Pakistan. I recently took PACES at Lahore Center, and as you mentioned, I passed it with a score of 163 out of 168. Now, I believe all of us are at different stages where we are taking this exam, and we are doing it for different purposes. Some of us want to go abroad to UK to pursue our career. Some of us want to make our CV better, and some of us want to do it for our personal achievement. So my story is interesting as well. By background, I am a trained family physician. So I got my training in UK. I completed my CCT there. And while I was doing that, I discovered that my actual interest was in dermatology. So I then started training as a dermatologist. Following that, we had to relocate to Pakistan because of some family reasons. So I had to decided to take my MRCP from here. Now, taking it from a different country, it was altogether a different experience. But what I have felt is that if you take this exam early in your career, it is far more easier if you take it later on. This is because with time, you develop certain habits which you have to first unlearn and then relearn. So if you're earlier on in your career, it's far more easier. It's not about a lot of clinical experience or a lot of clinical knowledge. um, it's a different ball game. So as long as you know the rules of the game, uh, you are able to make it even if you take it earlier on in your career. It was difficult for me to pick up books and to go through all those basic things after a long gap. And that is why I'm thinking, after going through the whole experience, it is quite a doable exam. You just have to know the rules of the game. Um, there is one major thing which I believe Dr. Huda has been telling us as well, and lots of other mentors have been saying that in their sessions too. There is one major thing that makes the biggest difference, and that is practice. So practice, practice, and practice. I cannot emphasize this enough. If you haven't practiced it enough, then you're not going to make it. As simple as that. There is no other way around it. So think of it as a way that you have to put up a nice show on the exam day. And if it is not appealing enough, your chances of making through the exam are less. So honestly speaking, it's the practice that makes the major difference. It overcomes your hesitancy and reluctancy. In exam, you literally have no time to think about answers and to think about logics. They should come as a spinal reflex. So if you've practiced it enough, if you have spoken it many times, you're not afraid to share your opinion at that time. But again, you will not get all the questions in the exam where you're 100% sure. So some of the questions will be new for you, but if you're at least somewhere closer to the answer, and you don't have to think a lot, then you are not going to miss upon the other components like investigations and management. You do need to speak a little bit on those components as well, because if you haven't spoken anything on those things, then you're certainly going to lose marks there. So it should actually come out as a spinal reflex. Um, some of you have personally messaged me and asked me different questions. So, for instance, some have asked, how early should you start preparing? Um, I would say it varies from person to person, but generally speaking, 2 to 3 months are good enough. People who are training in UK may need shorter than that, like 6 to 8 weeks, because they're in that system and they are indirectly practicing everything. But as foreign graduates, I think you should give it at least good 2 3 months. Bear in mind, it is an expensive exam. It is a stressful exam. Don't take it lightly. It does take its toll on your confidence level if you don't pass it the first time. So, therefore, don't make any premature attempts. I would advise that. It is better to take mocks before the actual exam if you're up for lots of actual exam experience rather than wasting your exam attempts. Then some of you have asked about resources. Um, I have only used a few resources. I haven't kept many books. So the things that I went, well, the books that I went through were Oxford Handbook of Medicine, Endurance Notes, Rupa Basant, and Short OSCE Cases in Clinical Medicine. So the last one I kept as my reference book. And it is important to keep just not have too many books where you're preparing from, because then it is difficult to revise it in the last week or the exam before the week. So at that point, then you start panicking about things. So you keep it short and crisp. Keep one main reference book. um, then some of you have asked about courses. Now, my take about the courses is, well, I do find them interesting because this is my second membership exam that I've taken. Before that, in UK, I took MRCGP, and we never had this kind of luxury there about the online courses. So with COVID, things have emerged, and these online courses have emerged as a very useful resource. So think of it as if, I mean, there are hardly anything anywhere in UK where you would find these kind of courses. So these span over a month, and you're practicing every day for 2-3 hours, and you are getting a chance to practice a case every day. You're in a hot seat, you're grilled every day. So without realizing, they're actually bringing out the best in you. So I would strongly recommend that you should enroll in these courses at least a couple of months before your exam date, so that all that hesitancy is gone. um, and you're in a good position then. The mentors on these courses, I have gone through Dr. Huda's course, and I would say that he puts in a lot of effort for you. So they make a research about all the recent exam cases, and so they prepare the agenda or the syllabus for the course. And in all honesty, these same cases are repeated every time. So if you have practiced them well enough, your chances are already high of passing the exam. So I would suggest that yes, you should go for these courses. Again, practice with many different people. It's great if you find one uh, regular partner, but um, I would suggest that if you're having one regular partner, there is a tendency that you would go into a comfort zone. So keep it diverse. If there are times you haven't got anyone at all, just stand in front of the mirror, talk and talk. Just take out that hesitancy out of you. One of the most useful resources, and my go-to website, was for patient leaflets, and this was patient.co.uk. If you go through those patient leaflets, they're written in very simple, useful language. So just pick up a few cases and rehearse them in front of the mirror. And you can pick up really useful phrases or sentences from those leaflets. Am I clear so far? Any questions?
Assalamu alaikum, Dr. First of all, congratulations for your success. Can you just repeat the website name you just mentioned?
Yes, it's patient.co.uk.
Okay, thank you.
Okay, so I'll go through my actual exam experience quickly with you through the cases. The first long clinical consultation was a 50 years old chap who was coming in with 10 days history of acute back pain. I have noticed that in these clinical consultations, they are giving one acute and one chronic problem generally. It's not necessarily every time, but generally. And these cases are now very much reflective of the true cases that we see in UK. So I have worked a lot in acute medicine and ER in UK, and these are the exact type of cases that we used to see there. So um, actually, there is no need to go into unnecessary details, long systemic reviews. You can cut them short. After practicing a few histories with Dr. Huda, I actually changed my history pattern just a few weeks before the exam, and it worked really well for me. So just saying, if you're presented with a main complaint, you just go through your OD para. You ask a few questions about your differentials, then ask about constitutional symptoms, ask about autoimmune associations like thyroid, diabetes, and Addison's, and then jump straight to past medical history, drug history, family history, and social history. Most of the times, your diagnosis lies in your past medical history, drug history, and family history. So if after going through the main OD para and constitution symptoms and autoimmune associations, you're not getting anywhere, rest assured that the actual diagnosis actually lie in your past medical history, drug or family history. So once you get your diagnosis, then you can ask the patient that I would just like to ask a few more yes and no questions, and you should go through the systemic questions. From each system, just ask one or a couple of questions, then do not waste a lot of time on too many unnecessary questions. And this is how your time management comes in the long clinical consultation. So make a target that you should be leaving your chair at the 6th minute and you should be starting your exam at that point. Also remember that history only contains 4 marks. The main mistake that we do is that we prolong it till the 12th minute. So we are working on those 4 marks till the 12th minute, and we have left all the rest of the components. So you finish with your history in the first 6 minutes. Now, if I tell you my experience in this case was interesting, because the moment I asked about the main complaint, the surrogate said, my brother has been having a sudden onset back pain. It started 10 days ago. It doesn't go anywhere else. It's about 7 by 10 in intensity. There is no fever with it. He has taken painkiller, but that didn't help. And it gets worse with coughing, sneezing, and bending. So believe me, this was within the first minute, he said all this. And this was like presenting a summary of a case. So I got the diagnosis, but I was taken back a little bit. And I was thinking, what should I be asking next? He has given me all the information already. What shall be my next question? So at this point in such situations, what I would suggest is take a deep breath and borrow some time by uh, saying some phrases like, thank you for providing all this information. That was very helpful. But I would like to ask a few more questions, just that I've got the complete information. And then go into your Socrates, and anything else that was missed in there. So the differential in this case were prolapsed disc, metastatic disease, and osteoporosis. The case was straightforward. And all that they were looking at here was whether the doctor asked about the red flags, whether she's able to prioritize the case, where does the case need to go, admission, pain relief, those kind of things. I would suggest whenever you are presenting your findings, you should have a template for that in your mind. Different people say different ways, whatever works best for you. Just make a template and try to present your case that way. For example, with me, whenever I used to present my investigations, I would have a brain map. So there would be some investigations which were confirmatory, some were general investigations, and some were to rule out complications. So I never started off by saying I would do just some general blood test first. I would start off by doing this or that. I would say I would like to confirm my diagnosis by I'm just giving example in this case. So I would like to confirm my diagnosis by doing an X-ray of the thoracic spine to rule out any fracture. I would confirm my diagnosis by doing an MRI spine to look for a prolapsed disc or soft tissue swelling. I would like to do a bone scan to rule out metastatic disease and DEXA scan to look for osteoporosis. In addition to that, I would do some general investigations, which would include full blood count, urea electrolytes, LFTs, ESR, CRP, and then if you think there are any complications of this condition, then you can talk about the investigations for complication. Try this template. It actually works for everything. Like if you put acromegaly in there, if you put chronic liver disease, anything, any diagnosis, it just makes it very easy for you. And whenever you are presenting your findings, just don't say that I would do this. Rather, try and say I would do this investigation to look for this thing. So just add a few short phrases. Why are you exactly doing that investigation? The next case was a lady, again middle-aged lady, who was presenting with upper arms pain bilaterally, with a fatigue for about 1 year, which got relieved after taking some homeopathic medications. But as soon as she stopped it, the pain came back. So all the candidates, including myself, we took it as a case of proximal myopathy. All we asked about was proximal myopathy, the inflammatory symptoms, and we were all focused on that. The only thing was when we asked particularly, was there any problem in doing overhead activities? She said no. There was any difficulty in climbing stairs? She said no. So um, then what they were looking for was on examinations how we rule out proximal myopathy. And the only clue to the actual diagnosis was on the wall where they had written BP and pulses unrecordable. That is where I knew that that was a case of some sort of vasculitis and not proximal myopathy. But we had to rule out proximal myopathy. Um, I lost a few marks here because I in the differential diagnosis, because I gave a differential of Takayasu arthritis and the differentials of unilateral pulseless disease such as thoracic outlet syndrome or subclavian steal syndrome, whereas this case was about differentials of bilateral absent pulses. So actually it was Berger's disease, vasculitis, or Takayasu arthritis. So that was the second case. Then came the communication skills. Both the scenarios which came in the exam have been extensively discussed in different forums. Dr. Huda has discussed these in his free sessions and the course as well. So the first one was talking to the patient who was attending for the results of his lymph node biopsy. The doctor had to tell the patient that the biopsy specimen was lost and to convince him to have the bronchoscopy done again. Now, this was obviously about dealing with the angry patient, accepting the error, and then convincing the patient. So when we were discussing this case, I think apart from myself, all the rest of the candidates said that they were not able to convince the patient to have bronchoscopy done again. The only thing which I did differently was, and you guys might have noticed this as well, whenever you go to these communication scenarios, and especially in the current, in the new diet, as they are putting different things together, just there should be two major things in front of you: what and why. So keep on asking these questions, what and why. Try and dig deeper. So if you think about this case, and if the patient tells you that I'm not going to have bronchoscopy again, this is a terrible investigation to go through again, you're just assuming that it is terrible investigation because it is uncomfortable, and perhaps that is the reason patient won't want to go through it again. What I asked him, was there any particular part of the test which was very uncomfortable? Um, would you like to do something? Would you like us to do something differently this time? And he said, yes, doctor. So just before the scope was passed in, I had a panic attack because of the fear of the scope, and I passed out. So I said, okay, in that case, what we can do is we can give you conscious sedation. We can give you some medications to prevent panic attack and keep you as relaxed as possible. We can spray the back of the throat as well with a numbing spray so that you don't have that uncomfortable feeling. And as soon as I said that, he said, oh, okay, brilliant. If that is possible, I'm fine with the test. I can have it done again. So that was easy after that. I mean, the usual stuff after that, referring the patient to Paul's, apologizing straight away. The next communication scenario was the patient with interferon gamma release assay positive test for latent TB, chest X-ray as a part of workup for biologics for rheumatoid arthritis. This scenario has also been discussed multiple times. The only thing about this one is that different mentors have a slightly different take on it. So some have said that you have to be 100% sure that the patient hasn't got active TB, and only then you can start treating the patient for latent TB. Some have said that the scenario already tells you that the patient has a negative chest X-ray and patient doesn't have any symptoms, so you can just go ahead and start the treatment for latent TB. To be honest, I wasn't sure, and this patient had a mother who was positive with TB, and she was looking after that as well. So I said, ideally, what we should be doing is we should have a negative chest X-ray, and we should have 3 negative sputum specimens as well, so that we are 100% sure, and then we can start you on treatment for latent TB. The reason being that latent TB treatment is different from active TB. So she went, oh, doctor, that means I need to have more tests then? And I said, unfortunately, yes, but I will discuss it with my consultant as well. And then I will get back to you. But just generally speaking, for latent TB, there are 2 different protocols that we follow. We either give you 2 different type of medications for 3 months, or we give you, very briefly, I spoke about the side effects of those medications. To be honest, there wasn't much detailed clinical talk involved in this one. It was straight away. I wasn't sure about quite a few things in there, but I played it safely that I would ask the senior, I would check the guidelines for you, I would take charge, I would come back to you, and I scored full in this scenario. So this is just at times when you're unsure, play safely and don't go beyond your limits where you're not sure. So this, in that case, went well. The rest of the scenarios were clinical scenarios. So in cardiology, I got dextrocardia with aortic stenosis. Neurology was cord compression with sensory level. Abdomen was chronic liver disease. The only peripheral stigmata that I could find was spider nevi, just a very few spider nevi, for which I had to literally take some time to expose the chest and then look on the chest here. There was no other peripheral stigmata present. And just because I had picked up that sign, I believe that's one of the reasons why I scored full in this station too. Respiratory was pneumonectomy with bronchiectasis in the opposite lungs. The examiner was a British examiner on this station, and she was very happy to hear the word pulmonary rehab in the non-pharmacological measures. So try and use this word. So all in all, the exam was not very tough. I think, and I felt it that way because I had prepared for good 2 months. I was very tough on myself as I prepared by using the actual exam mark sheets. Um, but if you prepare that way, and if you're tough on yourself in the preparatory phase, you're certainly going to score well in the exam. So that was all about my experience. If you've got any questions, I'm happy to answer.
Uh, he- Hello,
Hello.
Dr. Sophia. First of all, congratulations a lot. I
Thank
have a
you.
question. In
Mhm.
the clinical classification, sometimes the first concern of the surrogate is, doctor, what I'm suffering from. So in that
Mhm.
case, like, this is Takayasu arthritis, okay? So we have to give proper full explanation regarding Takayasu arthritis up till until the management as well in this concern. We have to
Not
explain
really.
the management in each and
Dr.
everything.
Huda, right. Dr. Huda gave me a very useful advice in this regard. Give information in chunks, okay, and allow the patient to ask you more questions, because usually the patient has a few concerns, not just one concern, so 3 or 4 concerns. So if you're talking non-stop and if you've asked lots of questions, well, if you have given lots of information and you haven't allowed enough time, you might not be able to answer all the concerns. So bear that in mind. Just briefly say this is inflammation in your blood vessels. We will be needing to do more tests about that. Um, and depending upon the situation, you can say we'll be keeping you in or whatever you're doing. So I'll be able to tell you more after that. Do you have any more concerns? So then they go to their next concern. Then you address that concern and you go accordingly.
Okay, thank you.
So, Dr. Sophia, what's your opinion about time management? Means consultation station, there is enough time?
Dr. Huda, I actually finished well in time. And the reason was, just as I mentioned with my first case, as this in this diet, they were experimenting as well, and they were even more cautious than us. So they wanted to provide us as much of information as possible without us asking them. So the surrogates told many things without us asking them.
Ask.
Um, and again, as I said, I have always kept a mark of 6 minutes for the history. I don't go too much into the unnecessary details of systemic review.
Yes.
Um, so I guess if you do well there, then you're fine.
And communication, Dr. Sophia, time is enough to explain for this concern and everything. You find it, time is enough, 10 minutes.
Um, to be honest, I think in the current diet, the way they are now combining 2 or 3 different things together, that is far more easier than the previous diets, because or the previous pattern, because there you had one problem and then you had to know ins and outs of that thing. Here now in the current scenarios, you just have to play with words. There are a few things, a few legal or ethical issues, a couple of them in a scenario that you have to know. So, for example, in scenarios of medical error, you have to apologize, you have to admit, you have to then refer to PALS, you have to tell them about risk management and incident report. That's it. And that would work in all the medical error scenarios. If they're angry, you have to give them time. You don't have to just constantly speak. So those little things, and you're done. You don't need tons of clinical knowledge, or you don't need a very good grammar or a very excellent English to deal with all this. These are just simple things. So I think now it's a lot more easier as compared to the previous pattern.
Okay, okay. Anyone has any
Okay.
question? I think Dr. Salim and Dr.
Uh,
Islam.
yes, sir. Ma'am, what was the age of the patient in long clinical consultation which has presented with the backache? And secondly, regarding your case with the dextrocardia, was it easily to pick up the clinical findings in that case? Thank you.
The long clinical consultation patient, both of them were middle age. One, I think, 45 or 50. Both of them were in this age. One was female and one was male. And the dextrocardia case, that was a thin, lean patient. And I spent a lot of time on locating the apex beat. But just as I couldn't find it on the left side, so I then checked on the right side and I found it straight away over there. And the murmur of AS was very classical. So I told them about these individual findings, and I did tell them that I don't know what's the significance of dextrocardia and AS together, but these are my individual findings.
Okay, thank you, ma'am.
Okay, I have a questions.
Mhm.
In the second long clinical consultations, you had a scenario like upper limb pain with fatigue. Okay. So in this case, we are also thinking number of possibilities, but in the consent part, if patient asks, what's wrong with me? Should we just elaborate one differentials that you are suffering from this disease and that's our plan, or just we say we are thinking the range of possibilities. How should be our approach? Should confine within one single disease we are thinking, and also there is possibilities are there, or just can say we are thinking a range of possibilities? What would be your advice, suggestion for us?
Right. Okay. So let's take the example of the second scenario, the vasculitis one. So all your differentials there are vasculitic in nature. It's some form of vasculitis, it's Takayasu arthritis, or it's Burgess disease. So all are some form of vasculitis. So in that case, to the patient, you only need to tell that there is some sort of inflammation going on in your blood vessels, and we need to look more deeply into that. So we will be running a few more tests. You do not need to go into the individual detail of your diagnosis. That is probably more relevant for you rather than for patient. But in the first case, the back pain case, in that case, if you're explaining it to the patient, your differential diagnosis are three completely different things. So you're thinking about cancer, you're thinking about weak bones, and you're thinking about a prolapsed disc. So you can, the way I started was, say, from the history that you have, from the information that you have given me, and from the examination, I believe your GP is right. He was concerned about a slipped disc, and I think this is what has happened. However, because your brother has got a previous history of prostate cancer, your concern regarding cancer would be very valid, and we would be looking into ruling out cancer as well. Along with this, one of the other thing that I'm thinking about is weak bones. Your brother is taking certain medications. He was taking the androgenic therapy. So your brother is on certain medications which can make the bones weak. So we will be doing some special scans for that as well. Do you have any more concerns at this point? That's it.
Okay. Okay, so we have to just explain 2 or 3 possibilities when we're thinking with a little elaborations. Okay.
Yes.
Fine. Yeah.
Exactly. Yeah.
So I think no one has any questions. Any chat box? Anyone want to ask anything? So,
Doctor? Hello?
yes, doctor.
Yes, I want to clarify something for me. That is gamma interferon. And if it is positive, we need to do an X-rays and sputum to exclude active TB.
Dr. Huda, what's your take on this one?
No, doctor, means in my view, they will do all the test. Okay, means X-ray is must. You cannot do only gamma interferon and did not do the X-ray. Okay, so chest X-ray definitely they will do it. So don't think in opposite way that only gamma interferon. Okay, so they will do the X-ray. If there is a sputum, they will do the sputum also. Okay, if there is no sputum, they will do the gamma interferon.
Okay, sound good.
Okay.
Hello.
Means a screening for the tuberculosis will be done. Okay.
Hello.
Yes,
Can I?
yes, doctor.
Actually, in the BCC, earlier there were only 2 minutes of interaction with the examiners. Now I think it is 4 or 5 minutes. So does it seem so difficult, or how is it like? Do they ask more
Before you know
questions nowadays?
before you know the time is gone. You don't literally have too much time. 5 minutes seem like a lot of time, but if you are presenting your findings just as I mentioned, the time is gone very quickly.
So you mean to say basically present slowly, or is that fine?
No. I'm not saying present slowly. You actually should be mindful of the fact that you need to cover all the components, like presenting your case, investigation, management, everything, because you're not telling each and every detail of management to the patient. You have to tell that to the examiner. So if taking too much time on just presentation, your history and findings and differential diagnosis, and you're stuck over there, then how are you going to talk about your management plan? If you haven't spoken at least a couple of sentences there, you will either get a borderline or a fail there. So you have to be quick enough, and that only comes if you've practiced well. So if you're fluent with things, you will not get stuck with things.
Okay, last question, doctor. How sure you were about dextrocardia actually by clinical examination just alone?
I think they usually put on cases which are classical cases. So I could not appreciate anything at all on the left side. I took a good time on Apex Beat. And the clinical courses which I have done, the first thing that everyone has said over there is that Apex Beat gives you a lot of information. So if you can't find your Apex Beat properly, the first or the next step that you should be doing is checking it on the other side. And I got it very clearly on the other side.
Okay, thank you. Thank you very much.
No problem.
Could you please repeat the name of the books you mentioned? I didn't get 2 of them.
No problem. I will mention it in the chat box.
Okay, thank you.
Ma'am, the last question from my side, because this is the gray area where I'm actually struggling, okay? When patients say I might need admission, some particular case clearly defined, okay, yes, it needs admission, sometimes not, but some scenario where we can take the bold decision as a doctor, yeah. But why your approach? I mean, can you just share your strategy where we're just facing confusions? Is the patient need admission or not? Because I don't sure about the diagnosis, thinking of differential. So what should be the approach?
Okay, so just as you mentioned, there are some clear-cut cases, for example, fever, who are in, they would need admission. But where you're not sure, what you can say is, for example, if the patient has presented in ER, you can say that we will keep you in our short stay unit for the time being. We will do all the investigations, and then I will come back to you to discuss it further. And that's absolutely fine. And that actually happens in the real life too in UK. So where they're not sure and they need some basic investigations doing first, they put them in the short stay unit.
Okay. Okay, I got that. So, yeah. I mean, OPD basis. So we'll did first investigation. Based on the investigation, we'll decide to retain the patients or not, right? Yeah.
Yeah. So where you're not sure.
Yeah. Okay. Thank you.
Hello, Dr. Sophia. Congratulations on passing MRCP. So just wanted to know how much time in a long clinical consultation we have and how we can do a systemic examination, divide the time in that each case.
So you have 15 minutes in total. The way I did was 6 minutes for history. Then start your examination at the 7th minute. Between 7th and 12th minute, you should be doing your examination. You should have completed everything. Then go to your explanation and patient consents.
Yeah, thank you. And where we can get this long clinical consultation practice? It's fastest.
Sorry?
From where we can get this practice long clinical consultation cases?
So just as I mentioned, these online courses is a very useful resource. The mentors collect all the recent clinical scenarios for you. So that is a good resource. Apart from this, yes, PACES test is a good resource too. And you have to keep on collecting the cases from different centers yourself, because there is a highly likely chance that these cases are repeated. So at least keep those in your priority.
Thank you. And how about the systemic examination, cardiology, neurology? Do the examiners will be standing in front, or you get the time to examine the cases in your way, or you have to be very systemic? What is like inspection, palpation, everything in that way?
I believe people have slightly, little differences in the way they examine things, but they're fine as long as, I mean, you're systematic, you're working with a good flow, and patient welfare is not at stake anywhere. So, generally speaking, I did my examinations mostly as these are shown in the past test videos. And because I haven't trained in Pakistan, so generally I have followed those trends which we were shown in UK. So let me give you a small example. So in Pakistan, my fellow colleagues who have done the specialization in medicine here, one of their favorite tasks is to actually measure the liver span. And so all of them have got the measuring tapes, and they would actually measure the liver span, and they would present their findings that way. I have never been told that. I don't know how to do that. I've never done that. So I always just present my findings by saying the liver is enlarged 2 or 3 finger breadth below the costal margin, and that is absolutely fine. So even there were British examiners who have been coming to the mock exams, and they've said the same thing. You do not need to make things complicated, just keep it simple. We don't actually know what the actual liver span, how much is the actual liver span is. So if you just say it roughly, 2 to 3 finger breadth, that is fine. So just keep it simple.
But suppose that you think that the patient has got COPD with coexisting chronic liver disease. So at that patient has got low flat diaphragm and upper border of the liver dullness may be downwards. So if you tell that patient has a 2 finger breadth of liver hepatomegaly, it will be then wrong. It's not it. Without measuring the total liver span in case of COPD or other disease that causes lowering of the diaphragm.
You're absolutely correct. But that's what I'm saying. Bear in mind, this is an entrance exam in UK. This is not the final specialization in your medicine. So the cases that they put in the exam are straightforward cases. They are not trying to judge your absolute clinical knowledge in gastroenterology or respiratory medicine. So this is one of the problem why people fail exam. We try to make it difficult for ourselves. The exam is a very fair exam and it's
Because,
simple. So
Sophia, you have only 5 minutes to examine the patient. 5 and 6 minutes.
exactly.
Yes.
Yeah,
So
exactly.
it's not possible. And there is an abdomen station. So you should not think of any respiratory cause there. Okay. So don't complicate, make it simple. Okay. So the station is very clear. It's an abdominal station. So think about abdominal causes and don't go beyond that. Okay. It's a 5 minutes is a very less time. You cannot do everything in a classical way.
Doctor, should we carry our own stethoscope and other things like the knee hammer and everything, or is it provided in the exam center?
Just carry your own stethoscope. The rest, everything is provided.
Okay, thank you.
Which mock test
Ophthalmoscope,
did you apply to?
Will they give the ophthalmoscope or we should carry it?
Right. Sorry, regarding the mock tests, I have only attended one that was in Rawalpindi, Islamabad. After the that was just recently in October. That was the only one.
Okay, thank you.
I have the question that in the exam hall, should carry our ophthalmoscope or they provide the ophthalmoscope for fundoscope examination?
They provide everything. I didn't take anything else apart from stethoscope.
Doctor, I have also one question. Congratulations on your exam, on passing your exam.
Thank you.
And what were your findings of neurology station? Sorry, I missed that part.
So neurology was cord compression with a sensory level at T10. This usually sounds as a difficult case, but I found this was the most, after obviously practicing, this was one of the easiest cases. This is because the patient is lying in that typical posture. The patient had contractures in the knees. He had a catheter attached to him. So when I started examining him, the power was 0. Tone was he had hypertonia, and the main thing in these cases, which can guide you, the single most important thing that can guide you is the planters. It's not the reflexes, it's not the tone, it's the planters. So if that there was in this case, the only positive finding there was upgoing planters, and no sensations till the level of umbilicus T10. So then you can confidently say that it is cord compression, sensory level T10, and then present your differentials there.
Sorry, doctor.
Okay, I have a question for you, doctor.
Hello.
Mm-hmm.
First, congratulations for passing. Okay, I have a question
Thanks.
that you're saying after 6 minutes we should start examination, right? In the LCC.
Yes. Mm-hmm.
How will you be able to confirm that the 6 minutes have passed on the basis of idea or any watch in front of me or anything like this?
Practice. That's the only answer to it. You don't have time to check time. Literally nothing.
Any
But
any watch in
no,
front
there
of
is
me?
nothing. There is nothing there, and I was actually very much concerned about that. I thought I would ask the examiner about the time when I'm done with my history, and it felt like I had taken a very small history, but actually nothing more was needed than that. So by the time you're done with this history, 6 minutes are gone, and you should start your examination straight away after that.
Okay, can I ask the examiner that how much time left for me? How much time is left?
Sorry?
Can I ask the examiner that how much time is left, sir? Can I ask it?
No need, doctor. Don't go for that. Okay. It's you
Can
don't
we have
time.
a stopwatch? A stopwatch with
No,
us?
there is no role of watch at all in the exam. You don't have time to look for. Okay. If you practice, you know how many minutes left, everything. There is nothing like that. Once you will practice 4 or 5 times with your partner or several times, you will have an idea. Your mind will, you can say that, okay, suppose your friend has put 14 minutes. You will pick that, oh, okay, he's not telling 2 minutes left. Okay, so it's all about practice, doctor. No need to, you don't have time to see, look on the watch. Okay, once you will practice, you will realize it. I think those who have given the exam, they know it. No time to, there is no role of wristwatch or any watch, okay, in the exam.
I have one question. In neurology station, should we check the gate last only, or can we check the gate in the beginning and then do the other test?
It's entirely up to you. So in cases like in this case, which I mentioned, where you feel like there is no point of checking the gate, then obviously you start with the examination. But if you want to check the gate first, it's entirely up to you. There's no problem with that.
And one thing, if it is written in the on the paper that examine the gate and proceed accordingly, okay? Or this man has difficulty in walking, examine the lower limb. Then you better to check the gate first. So you will tell the examiner, okay, that I would like to check this patient gate. If they will allow you, it means patient has something there, finding is there, okay. If they will tell you no need, okay, proceed. So you first examine the lower limb and then at the end offer the gate. This is my view, okay. But because particularly in the hemiplasia, it's very easy. Means if you will check the gate first, you will know the diagnosis, okay, and everything. So sometimes examiner not allowing you also. Even the patient can walk, they will tell you no need. Okay, examine and do the gate at the end, okay. So because they know that once he will walk, you will know the diagnosis. So I think no one has any questions. So thank you so much, Dr. Sophia.
No problem,
Doctor, can I ask you a question? Sorry about that. So
Yes,
congratulations, Dr. Sophia. So my question is regarding the neurological examination. So in sensory examination, do we need to do all the like fine touch, then the pinprick sensation and joint position and vibration as well? Like all 4 of them?
Yes, so if you're checking the lower limbs in neurology, then you need to do that. If you are doing it in the long clinical consultation, and obviously that is the lower limb examination is not the only thing that you might be doing there. So then it is okay to just do one modality from each.
All right. And as your case was a back pain, may I ask you, like, what did you examine?
So in that case, I started off by examining the back. So exposing the back properly, front, back, sideways. Then I asked if there was pain, particularly where was the pain, and he pointed to the mid-thoracic level. And then I asked that I would slowly press on the spine, and I'll be gentle, and so I warned him about that, and then he winced at T8 level. So I knew that it was in the thoracic spine. So then asked him about just generally bending forwards, backwards, sideways, twisting side to side. Then I went for lower limb examination straight away. So just did the neurological examination, and that was it. In addition to that, we had another case during our mocks, exactly similar type of case, but in that the patient was having fever. So if fever comes into play, then you have to think about discitis, and you have to look about other sources of infection too. So in that case, then you may need to do the abdominal examination for kidney infection, bladder, those kind of things as well.
But in
Thank
this
you,
case, if we have differential diagnosis of disseminated malignancy or disseminated tuberculosis, suppose, then should not we also examine the abdomen and lungs?
So I did ask in the history if there was any, constitutional symptoms I asked about, which were not there. Then I asked about, was there any contact with any person who has been very chesty or who was known to have tuberculosis? And he said no, there was no history of foreign travel. So they kind of excluded tuberculosis. And I then, in the systemic review, there were no respiratory symptoms either. So I did not do any respiratory or abdominal examination. It was straightforward.
But you have differential diagnosis of disseminated cancer from the prostate.
Mm-hmm. Yeah.
So should not examine the abdomen?
Yeah, then again, you will be running out of the time. So technically speaking, you can do for disseminated disease, you can actually examine the patient from head to toe, whichever system you like. But then they actually particularly asked me the question, was there any other source of infection that you think there might have been? And I said, on the systemic review, I did not find any source of infection or any other symptom. And they said, okay, that's fine. So if there was no other symptom, then I guess I did not need to examine it in that scenario. The focus was mainly on compression, the nerve compression, the red flags with the back pain, and the examining the back itself. So in this scenario, they're actually trying to see whether the doctor is able to judge whether this patient needs to go to neurosurgery straight away, or they can be admitted and they can have MRI done on a non-urgent basis or urgent basis, or what should be the course of action. And then they did ask me about what sort of pain relief would you give this patient. So then you have to know about the WHO pain ladder. The patient had cocodamol, the patient had NSAIDs. So what comes next in the WHO ladder? It was tramadol, stronger opioids, morphine, and then if it was confirmed that it was metastatic disease, then localized radiotherapy can be given, those kind of things.
Thank you so much, Dr. Sophia.
No problem.
Thank you so much, Dr. Sophia, for coming. Okay.
Yeah, Dr. Sophia, thank you for sharing the names of the books that you went through. Could you also please share your preparation strategy as to how you prepared over the past 2 months?
So just as I mentioned, I went through these notes, the books, and then just went through I enrolled into a couple of courses. One was Dr. Huda's course, and then I found a partner online with whom I practiced. And for the clinical practice, there was there were two other doctors that I was practicing with in different hospitals. One was a lot more senior than me. So he had lots of knowledge. I learned a lot from him. And the other one was a beginner. So I had a diverse group to practice with, and that helped me a lot. So to be honest, my practice strategy was just talking as much as I could talk, and discuss it with many doctors, whoever I could find, but not to get distracted from my own pathway. So I had a target that I have to finish this by this date, and then I have to practice it with many people too. So try and keep your group diverse, but don't get detract. You do have to finish your syllabus as well.
Okay. Okay. Yeah. Thank you.
No problem.
So thank you so
Thanks
much, Dr.
for sharing. Yeah.
I think Dr. Jennifer, are you there?
Hello, sir.
Hello, congratulations, Dr. Jennifer.
Thank you, sir. Thank you.
Okay, so thank you so much for coming to our free session. Okay, actually, so how you are feeling now, Dr. Jennifer?
Oh, quite relieved, sir, to be
Okay,
honest.
so we want to know India Center perspective about from you. Okay, so any candidate who are going to appear in India Center, so they have a different set of questions. Okay, so just you can elaborate how you prepared for the exam, and how you think that our candidate will do better if they will appear with a plan in an exam in next time.
Sure. First of all, thank you for letting me speak today. And thank you to Dr. Sophia. She has given a very comprehensive, she's mentioned about everything. So thank you for that. I'm sure it will be very helpful for everybody who's attending. In my case, my background is that I'm an MD in internal medicine, and I'm trained in South India, and I'm currently working in Doha. So there were a few things. That is, I was out of touch with clinical medicine because I had recently relocated and had a child. So because of those two factors, I was out of clinical experience for a while. So that was a little tricky for me. And I was not very confident to go for the exam suddenly, and I didn't have any access to patients because of my recent relocation. And I wasn't working at that point of time. So that was one challenge. So I started off with, honestly speaking, my exam was in end of November, and I started end of August with Dr. Naseem sir. He's my first and only mentor. Thank you very much, sir, because you put a lot of effort in me, and I've put my entire trust in you, and I have followed whatever you've said. So thank you so much. And sir had a course, group. I mean, it was a group session, which 5 or 6 of us. We started with clinical consultation and communication practice. And I remember in the initial 2-3 days, sir would give me a case, and I would be like, sir, I have no idea how to do this because I hadn't attended any session, nothing before. It was just new. I got my date that I have a center. I somehow came across sir's group. I joined. That was all. So I started, and sir would give me communication scenarios, and I had no idea. I literally remember being so embarrassed, and I'm like, sir, I have no idea what to do. My only reference were the one or two people who had presented before me. So that is how I started in the end of August. By the time we finished in the, I think, end of September, I was quite confident to deal with clinical consultation and communication, thanks to Dr. Naseem sir and my group members. And later on, we practiced amongst ourselves, forming a small group. And that was also, we all got introduced because of sir's group. We were all together in that sessions. So we all knew what we were dealing with and how to go about it. And we all had that same approach because we were all guided by sir. So that once I finished end of September, once I finished sir's course, that's when I realized that PACES is not only about communication and clinical consultation, and started panicking again because I was still not having any access to patients. That's when I started my work in Doha and slowly started seeing a few patients. But I felt, but there are still things that I would advise you people who are listening today to follow, but which I couldn't do. Unfortunately, it was very last minute by the time I realized a few things. So my preparation strategy, I mean, this is not my strategy, but the advice I want to give is I don't think too many books are needed for PACES, to be honest. If you have a basic knowledge about, the basic things that we see, then you don't need to read too many books. You can read the most simplest books which is available. One of the easiest, shortest, and most concise books, I think, which is available is Cases for PACES. I read that, and actually, I felt that they've not asked anything more than that in my situation. Like when I went for the exam and the course that I attended, the clinical course, there was nothing very serious asked, like nothing fancy was asked. It was very simple, like what is the complication, this, that, very simple things. And all of that is mentioned in that book. And I really don't feel we need to read too many books, because in the initial phase, when I was panicking, I was trying to figure out which book to read, which is the next book to read, what more to read. But I don't think that is needed. After going for the exam, I'm quite sure that all these books are not needed, especially because there's no time for anybody to ask very elaborate questions. They're asking the most basic questions, like what is the finding, what is the DD, what is the complication, what is the treatment, like very simple things that you would be wondering, okay, is this PACES? And it is not at all like how our Indian exams are. It's very simple, and no one is going to fail us, or for a simple like it's not very fancy. So basically, I felt after my exam experience that if we are in an Indian exam, I would have probably not cleared, because I felt that I made a mistake in clinical consultation. I had spoken to sir also about it. But when I got my marks, they've just deducted very few marks for that. It's not a pass or fail kind of thing. But in India, if you don't say one thing, then they would probably fail you. It's like that. So this was very, I felt that it was too fair, that I was quite surprised when the marks came out. So basic thing is very few books, very simple book, a very good partner or a few partners, and to be practiced. Because when you go into the station, you have very less time and you're very anxious. So the best preparation is practice. You have to be so practiced. And one clinical consultation that I got, the reason I didn't do well in that is because I hadn't practiced that scenario. If you practice a scenario, you are so confident while you're there, it's so smooth, and it literally shows. But the second, and in one clinical consultation, which is very common clinical consultation, and I had practiced it before, it was basically ankylosing spondylitis. and I've got 28 out of 28 because we had practiced it. And there's nothing major that they ask other than what we practice. Very simple questions, what the examination, everything is practice, so we do it. It just comes in a flow. And the other consultation is a topic that I hadn't practiced, or I felt I haven't practiced. I don't really remember having come across this topic before. And I kind of, that was my initial station when I start the exam. And I was already panicking because I felt I have not read about this or practiced about this station. So I was a little nervous, not little, I was very nervous when I went in. It was basically given that the patient was confused, and it was mentioned that the patient is diabetic and the patient had heart surgery. This was what was mentioned outside. So I was already, a little panicky, and I was thinking it could be some metabolic cause because they've said the patient is diabetic, blah, blah, blah. And in no time, the bell rang and I'm inside. And I was literally very panicky. I know how to approach the case. I did, but I was not comfortable because I knew that I have not practiced, and that thought just kept coming back. And yeah, that went on, and I gave my DDs and stuff. But anyway, since I was so anxious, I couldn't literally cover everything. It was not very organized, the history, the examination. I looked a little, I was definitely looking unpracticed. So, and since it was a long case, I was very nervous that this is going to affect my entire score and everything. And that was my starting station, unfortunately. Anyway, the next was from then on, luckily, all the other stations went okay, especially communication. All the cases were the ones Sir had discussed in this diet. The same case has come. Most of you might be knowing one case is the pilot who has a pneumothorax. That was one case. It has been discussed by Sir, and I think many mentors have discussed in their free sessions. And then there was another breaking bad news. So it was all discussed. So I think if you practice, especially communication, clinical consultation, you can get a very good score. And for examination, other cases, those 4 cases, you have to practice examination every day on somebody so that you're fluent in the method of examination. I haven't done that, honestly. I just kept it to the last. And honestly speaking, I would have practiced this in less than a week before my exam. But it literally showed, and I was very nervous because of that. But if you start practicing the technique earlier, it becomes much easier and it will just flow. And the questions asked after the exam also, you need to have a pattern in which you would answer so that these answers come out in a very systematic and fluent manner, so that there's no ifs, buts, like pauses, all those things. It will just come out smoothly, the way you present the clinical cases and the investigations and management. So if these things are practiced, and I think clinical stations also should go very well. Yeah, that's about what I have to say.
So thank you, Jennifer, for sharing your thoughts and your experience. Okay, we are very happy that you shown the faith on me. Okay, and I know it, so I was also preparing, doing prayer for you that you should pass. Okay. Okay, so thank you so much, Dr. Jennifer,
Thank
for
you, sir.
our session today. Okay, so we are running out of time. So I think Dr. Nigar, if there, because she is the Jennifer partner, I invited her also.
Assalamu alaikum, sir.
Walaikum salam. Okay, how are you, Dr. Nigar? Many congratulations.
Alhamdulillah. Alhamdulillah, sir. I am good. How are you?
Okay, so now you and Jennifer together there in our session.
Like old days, definitely.
Yes, it's the our regular session timing. Okay.
Mhm.
Yes, yes.
So, Dr. Nigar, share your experience about the Pune Center briefly, just about how
Okay.
you, because it's a new center, so
Mhm.
there's no idea about it. So, just to help others, how you feel that about the center, because no one has idea before about this Pune center.
Sure, sure. Thank you so much, sir, first of all, to letting me talk today regarding my experience. Okay, so I selected Pune. That was a new center just because it is near to my house. That was a decision which was made because currently I'm from Mumbai, but currently I'm living in Dammam since last 6 months in Saudi. So I have to come to some place which is familiar to me. I didn't want to go any place which is like completely, totally unfamiliar, which will get me anxious. So that was the reason for me to take a Pune center. But obviously, I was anxious because this was the first time they were conducting the exams, and you don't know the examiners, you don't know the patients, you don't know the staff which were managing. Those things were there at the back of the mind, but everyone and especially Dr. Naseem told me that the all thing will depend on your preparation, what you are doing. That will all depends on that. Nothing else will matter at that moment of time. Fortunately, the exam was very well organized. The staff was very helpful. The examiners were very good. And one thing I just wanted to tell, it was told to us that you're never supposed to talk in your native language. And I was like, okay, that's fine because I have practiced in English all the time. But when I reached the exam center, the British examiner, he came, he was like, if you people know the local language, it is okay to give commands in those languages to respond to the patient, because we have another examiner is Marathi examiner, so they will understand it. That is not a problem. This was one of my doubt which was there since starting when I took the Pune center. So at that time, before the start of the exam itself, they came and they just said, okay, be relaxed. If you know the language, you can give commands in your own language. It's fine because they understand. The other examiner will understand your language. So it's okay. So that is one thing which was comforting me at that moment of time. Apart from that, I started with my the station. I started with long consultation station. It was a case of normal from outside. It was breathlessness was an exertion since last 3 months, and it was a middle-aged man who was looking completely normal to me. And when I asked him the history, except the breathlessness and exertion, he was saying no to everything, including when I asked any racing pacing of the heart as well. Then I was like, okay, I'm not reaching anywhere. It was like, I guess, 7th minute. I was like, okay, I'm not reaching anywhere. It's better I should go for the examination now. Okay, so after I asked every question which is required according to the pattern which was given to me by Naseem sir. I asked everything except the smoking and everything, personal history, which I kept like, okay, I'll ask it later words. So before going to the examination, he said, okay, doctor, one thing I forgot to mention you that I have some self-awareness of my heartbeat. I didn't that he mentioned at last before I start the examination. I was like, okay, it is something to do with some regurgitant lesion there, because rest of the symptoms were in that accordingly. So after that, I got a murmur which was radiating to the axilla, and thrusting apex beat was there. So I not thrusting, that hyperdynamic kind of apex beat was present. So I gave a differential of mitral regurgitation in that case. And they asked the history, they asked the things regarding the causes, what are the complications, and how you're going to manage, would you like to admit the patient or not. So they see that the basic thing which they ask normally. Okay, once you have done your examination and history and examination is completed, take some time to just think back what is happening, what is it exactly, and you start explaining to the patient. And just take a pause in between, let the concerns come from their own side before you asking them any concern. It's better, because if you're giving a pause in between, or you're asking are you understanding everything, they will ask you the concerns at that moment of time. That will save your time lately. Then the after that, like as mentioned by Dr. Sophia, those 5 minutes with the examiner, it goes like you even don't even thought like how fast it can go. Okay, so that was the thing. They started the same thing. Like first you present the findings. What did you get in the patient, and what are your differentials? How are you gonna manage? Would you like to admit the patient? What are the complications? What could be the causes of it? So as Jennifer rightly told, basic information is required. They are not expecting any high level information, because it is your entrance exam. It is not your so-called qualification exams or any, like, they're not giving you a degree out of it. Okay, you are supposed to do CCT after this, not right now you're doing that. You're just entering it right now. So just they want to check that you should have a basic idea and you should be a safe doctor. Like if you are having any trouble in anything, like in this situation, would you like to admit the patient is having shortness of breath since last 3 months, okay, and he is not having any red flags at this moment of time, so he does not require admission at this moment of time, but provided the echo should be okay. So I mentioned, okay, I would like to first do some investigations first to confirm my diagnosis, to check what is the lesion exactly and what is the significant, how significant the lesion is. Accordingly, I'll take the decision regarding the admission of the patient. So they were okay after that. So just be smart how you're answering those questions. It is not necessary you should know everything. You can always take a time, okay, I will come back to you after the investigation. That is fine, that is fair. Rather than taking everything on your head, like, okay, I will admit you or I will send you home. It's not required. Okay, that will be a decision by a senior authority, not you anyhow. Okay, so this was my first station. After that, there was a cardiovascular station and neurological station. In cardiovascular, it was MR versus AS because the murmur was radiating to the axilla as well as aortic region along with the carotid. So there was a query. So I gave both the differentials to them and they were quite okay with that. And they asked the same thing, how would like to, the Viva went after that on aortic stenosis. After my presentation of the case, they asked me regarding aortic stenosis investigation management, what treatment options are available, what is the indication for the surgery, and what surgical options are available. Like they wanted to hear about newer TAVI and TAV, those things. They wanted to know about it. After that, the next station was a neurological station, which was little tricky for me initially because it was a lower limb examination. In that they asked first like to start the examination, and the patient was having weakness but it was not very severe, and it was looking little bit of wasting which was there in the legs. That means there was some chronic thing which was going on for the patient. And after that, I was doing the sensory examination in detail because I was not able to, because there was some sensory loss present in those patients. So I took that modality in detail as well. And at last I was left only with like 40 seconds before I can ask the patient to walk. So like when I asked, like I would like to ask the patient to walk please, to check the gate. The examiner asked me, you have only 40 seconds left. Like I said, I would like to do that, please sir. So he allowed me, fortunately. So I did the and it was definitely a cerebellar gate present in this patient. So I gave the differential of spinocerebellar ataxias in that station, and alhamdulillah I scored good in that station. That was because it was very unpredictable. It was very confusing for other candidates as well. So that was good. Then one thing I would like to mention it, like in this case I didn't get time to finish the examination completely because I have to check the sensory examination in detail. But if you are if the sensory thing is normal, you are having some time, you ask the examiner, like for example, if you are getting a patient with having spastic paraparesis, for example, with no sensory abnormality at present, and you are still left with 1 minute or something, so ask the examination for the permission to check for the upper limb if it is possible. So that will help you to localize the lesion, because just spastic paraparesis you will not be able to confirm anything like what is the cause and everything and where is the lesion exactly. If it is possible for you, you have time, if you have time, you can take that advantage to examine the upper limb. Back you have to check anyhow for the lower limb examinations. There is no exception to that. If you are having any lower limb examination problem, always take an opportunity to check the back of the patient. Okay, there could be any scar, any swelling, could be anything. Okay, so this was the neurological station. After that, there was a communication station. Fortunately, very fortunately, I got both the communication stations which were there for the previous exams, and Dr. Naseem has already took those sessions for us. So that was very helpful at that moment of time. For first communication for me was a patient who was having presented to me with the case was a CT brain with metastasis, and your task was to breaking a bad news basically. So just mention it was a known case because it was there in 3-4 centers previously. So just be sympathetic, empathic towards the patient and answer the concerns. Most importantly, provide the support to the patient that okay, we are here to support you all. Refer to various things which are required, like social workers and occupational health physicians, those things are really required. And take up pauses in between. That is really important. When you are breaking up bad news, the most important thing is first warning shocks. Another important thing, do you want anyone to be present for your support? That should be important. That is very important. And after warning shocks, when you gave the diagnosis, the bad news to the patient, wait for a second there. Wait for like till the time he replies, the patient replies, wait till that time he replies. Don't interrupt in between, don't say anything in between, except you can offer some tissues and water if it is present on the table. That will be a good gesture at that moment of time. Okay, if he's saying okay, I'm okay doctor to continue, then you can go ahead with the rest of the things. Okay, so that is for the communication. After that, I had another station was consultation 2 for me. Was fortunately it was a surrogate case, definitely, because the history was complaining of headache since last 3 months, and patient was on asking the history, he mentioned that he is having difficulty with he's bumping into the objects. That was the history was given to from the patient, and it was very much obvious history which was given to me in like first or second minute itself. So that was very clear, it is something to do with the pituitary. Now we have to see the causes for it, what is the thing, and rule out the complications per se. As I mentioned, it was a surrogate. There was nothing else positive. He was not having acromegaly. He was not having prolactinoma. So we just have to give the differential diagnosis. Okay, it could be non-secretory tumors. It could be any other possibility like craniopharyngioma. Those differentials need to come, but make sure you have ruled out the red flags in that as well, because that is really important to have, like Addison's, any features of Addison is really important in those patients. So that was there. And in that case, like being a case of pituitary and having a vision problem, detailed eye examination was required for the patient. So I did that. The thing came for the ophthalmology, like for fundoscopy, that I was really afraid because I'm not very much expertise in doing fundoscopy. So I just offer like, okay, please say no, in my back of the mind, please say no, don't do fundoscopy. So unfortunately they said, okay, it's not needed. Patient is having a normal vision, it's not needed for you. I like, okay, thank you so much. Then I proceeded ahead. And the Viva was on like what are the differentials and what could be the management. So that was it. After that, the another communication station for me was a case of it was a case of delayed UGS copy. Again, this case was discussed by many mentors. In fact, Dr. Naseem also discussed this case in a free sessions. So it was a delayed endoscopy because of any other patient in the trauma, and you're supposed to talk to the patient whose endoscopy was delayed. So just, yeah, you have to supposed to I will not say apologize, because it was not a mistake, but just sympathize with the patient. Say, sorry, I'm really sorry for your suffering and the problem which you have suffered because of this thing, but let me explain it to you what happened exactly. So you just tell the thing in a good way. And the most important concern from their side will be, do you think I am not important or what? I came here because of some symptoms, and you're saying there was another important patient, so what do you mean I'm not important? So you just again say like, okay, I'm really sorry if you felt like that. Okay, it is not like that. The patient required the procedure very urgently. It was life saving for him. So we are trying to get it done for you also as early as possible, because we don't discriminate between the patients. Each patient is equally important for us. It is about the situation, how we are supposed to manage. Okay, so then the rest of the thing followed after that. Basically they were asking the concerns in between. It is not like only last 2 minutes are there for concerns. No, if you're giving adequate pauses in between, they're asking concerns in between itself, and you're getting those marks for your concerns there itself. Okay, so that was the second communication station. After that, I had respiratory system, and fortunately, it was easier one for me. Alhamdulillah, it was a case of patient like female was sitting in front of you, and by looking that female, you can say, okay, she's systemic sclerosis. So that was the case, and so we started like, but one thing is really important when you're getting these cases, you should be focused what you're supposed to definitely check in those patients. Like for my patient, there was sclerodactyly, there was changes, there were pulse was having atrial fibrillation was present in the pulse. It was of low volume. JVP was raised for the patient. There was no clubbing per se. On auscultation, there were crepitation. JVP was raised, and patient was having parasternal heave as well. So for the complete diagnosis, you are supposed to tell everything. Like this patient is a case of interstitial lung disease with secondary pulmonary hypertension with atrial fibrillation, most likely due to systemic sclerosis. So these all things should come. Then how would like to what would be your differential diagnosis and what would be the investigations? Those you're supposed to mention to the examiner, and how would you manage that patient? So this was that. And in and all, the exam was very good. They were helpful. They're not trying to pull your legs like most of the Indian examiners do. So it was a genuine exam, and Alhamdulillah, everything went good. Everything went good, Alhamdulillah. Yeah.
So center
can,
seems like okay, is good center.
Yes. It's a good center, very organized, I would say. Yes. And the
How is
staff
the
is very
surrogate?
helpful.
Surrogate are good trained, well trained.
Sir, one of the actually the first consultation station which I got, I really still have a thought that he was not a patient. He was some professor who was having some murmur, just a symptomatic murmur, because of which he was sitting there. Because the way he was behaving at that time, it was quite obvious, like, okay, he is a person who knows everything.
Maybe he has MR and
yeah, quite like MVP and MR, which is asymptomatic, and he was sitting there, or maybe just simple like that way. So surrogates were good.
I think Nigar, now I remember, we discussed the case, na? You asked me the question that time. You remember a case, aortic regurgitation, Marfan, we discussed palpitation.
Yes. So yeah, that was it.
I have a query. In the clinical stations, what is the time given for examination and how many minutes for the question answer session in the clinical station?
In clinical stations, you have total 6 minutes. They give warning at when 1 minute is left. They give warning to you, and 4 minutes for the question answer session.
Okay. And in female patients, how much should we expose, or how should we approach a female? How much to undress them?
If it is a respiratory case or cardiovascular case, there is a curtain, curtain just beside the patient as well, but the room is closed one. So with the asking the permission of the patient and the examiner, you're supposed to expose the patient the way we do normally in Indian exams as well.
Okay, thank you.
Welcome.
Okay, ma'am. You said that in cardiovascular examination, you have mitral regurgitation as well as aortic stenosis. I mean, so in the differential sections, okay, can you mention aortic stenosis along with mitral regurgitations? I mean, what was in the real scenario? I don't know. Did you put the GD in a separate or isolated manner, or just in a combined
I just mentioned that I would like to I'm thinking that there are two different lesions in this patient, because the murmur which I'm getting at the apex, it is radiating properly to the axilla, and another murmur has different character altogether, and it is going till the carotids. So if it is going to the carotid, you can't give pulmonary regurgitation or pulmonary stenosis or anything at that way, because it is going to the carotids. So that's why I said, okay, sir, I'm thinking there is a two different lesions, and they were quite they accepted that thing. They didn't ask anything after that. My viva went on aortic stenosis. That was a thing. And I don't know, there could be, I could be wrong that it could have been single lesion, because I got like 15 out of 20 in that station. That's it. That much I know right now. So I didn't receive the feedback yet. So when it is available, I'll share with sir again.
Okay, and the second question, okay, in some scenario like systemic sclerosis with pulmonary hypertension and with atrial fibrillations, in such scenario where there's diagnosis is clean card, okay, so how should we approach in terms of differential, okay, because we know in systemic sclerosis actually differential.
Yes, in those patients, like this is a case of interstitial lung disease along with pulmonary hypertension and atrial fibrillation. The differential diagnosis, the cause could be, underlying cause could be mostly systemic sclerosis. I would like to give differential for the causes for it. So in that, there could be MCTD, there could be another connective tissue disorders that you can mention.
Okay, thank you.
That is not responding, that is
I think no one has questions now.
Yeah, Dr. Zenifar, can I ask you a question?
Yes,
Hello.
sure.
Yes. So my question is like in your recipe case, you mentioned about this ILD with right-sided heart failure with pulmonary hypertension. So like, what was the features of ILD? You could not appreciate any clubbing there, right? Did you find any
In
fine crepitation?
Yes, there were crepitations, of course. The examiner was basically asking questions like where else in the upper zone is there crepitations. So sometimes you have your findings, you have clubbing, you have crepitations. The examiners might, probe you to see if you cook up any more findings. So he was asking me, are there crepitations in the upper zone? What did you hear in the apex? So, yes, whatever findings you get, you put those findings and don't fall for that trap and give more findings which are not there.
Okay, okay, I got it. Thank you
There
so
was
much.
crepitations, there was clubbing, and I don't remember if there was pulmonary hypertension. Actually, I don't remember if it was there or not now.
Yeah, basically
Dr.
I asked
Jennifer,
you this
I have
question because I saw some patient like they have systemic sclerosis with pulmonary
Yeah.
hypertension, and due to pulmonary hypertension they develop right heart failure, but they don't have any
No, no,
underlying
my
ILD. So that's why I
no,
actually
no.
asked you.
There was no right heart failure. I mean, there was no other signs other than the pulmonary hypertension. There was no edema. There was no swelling of the legs. Nothing was there. So it was just a old lady with a frail lady with clubbing and anemia and crepitations, fine crepitations.
Okay, okay. Thank you so much. Thank you so much.
Dr. Jennifer, I would like to ask you about the first case, which was confused
Yeah,
diabetic. So, how
yeah.
did you take the history from the patient?
Yeah, so actually, when I went inside, it was from outside, the only information was the patient is confused and the patient is diabetic and that the patient had undergone heart surgery. And when I went in, so my thought process was like, this is probably something metabolic, like hypoglycemia or diabetes related something. And because I have not practiced, haven't thought, I was nervous. I couldn't think of anything other than several metabolic causes. So when I went in, there was a surrogate who was sitting who said that this patient is my uncle and I am the nephew and he is confused. So this is what he said in the beginning, and the patient looked very normal to me. So then I wanted to ask, so I was confused. I myself got confused as in, is the patient currently confused or was it just a brief episode and then he has already recovered? The surrogate kept saying he's confused, but the patient looked very normal. He was very, so it wasn't matching. So I was wondering, did the confusion resolve? What happened and all that? So initially the history was that this patient had eaten from outside a few days back, and he subsequently had loose motion and vomiting, and after that he has become confused. So then I was initially asked, pardon me? Yeah, so I was basically asking if anyone else in the family has eaten with him and anyone else has the same problems. So they said no, everybody else who has eaten with him are all fine, only he developed all these problems. And he had vomiting. So this patient had a heart surgery. So he had, they didn't say what heart surgery and all in the beginning. So in the history, I found out that he had some heart related surgery for a valvular problem. So he had a median sternotomy scar. He had a valve replacement surgery and he was on warfarin. And the basic DDs that I presented was that because of the vomiting, and he had a big drug list. His medication list were about, I think, 10 or 12 medications were written. So everything was looking problematic. There was warfarin, there was some diuretic, I think some antihypertensive medications. There were many things in the drug list. So then I came up with hypoglycemia, hyponatremia, all these metabolic causes. And what they also expected was a TIA because the patient had vomiting and obviously he was taking his warfarin, but then we don't know the levels of the warfarin and things. So what was asked is what all investigations you want. So you want to check the INR, you want to check all the electrolytes. So basically, it was just DDs were metabolic encephalopathy with either hyponatremia, hypoglycemia, and another DD-TIA. This is what because of the valve replacement, and the patient was on warf. So this was the gist. And the patient, and they also mentioned that the patient was depressed. So the patient was depressed because I probed into all of that, and the patient was depressed because his wife had passed away. So then I was thinking in terms of that as well, like, because of his depression, he was on many the psychiatric medications. I don't remember what all medication, but there were 2-3 medications in the bottom of the list, which were all psychiatric medications. So, all of that also cause hyponatremia. All these psychiatric medications can push. So I was thinking of all these causes. And then there were some cuts on his hand. These were not looking like hesitation cuts, but then there were several cuts on his hand. And I was wondering, okay, now is it hesitation cuts? Is he doing some sort of self-harm, or is it just delirium? I was just confused. But then the examiner later on said that the job that he had said in this was he was a clerk or some normal job. I don't remember exactly. But so he said, no, it is related to his work that he has got all these cuts on his hand. It is not related to the, self-harm or any of that thing. So this is what it was.
Okay, ma'am, I have a questions. Okay, during the clinical stations, okay, after finishing the 6 minute, did the examiner allow us to complete the finishing statement, like I'd like to complete my examinations by doing this and that? So just included within the 6 minutes.
Yes, if you, especially in neuro, sometimes you don't get the opportunity to finish. So what I got in neurology was cranial nerves. It was least expected. Everyone, I think, gets lower limb, and some people get upper limbs. So when I went in and they said cranial nerves, first of all, I was a little shocked. But then, yes, I started examining, and the command was to examine the cranial nerves. So I started examining from the first cranial nerve onwards, and I did all the cranial nerve examination. And after that, I was going into looking for any other weakness and cerebellum. I wanted to check these two things as well. But time ran out.
But
I couldn't do cerebellum.
did they allow to complete the last statement? I mean, when examiner said yes,
Yeah.
your time is up, did they allow to say
No, so he did
mention
ask what
last?
else. So I gave my DDs, and he said, what else do you want to examine? So I said, I want to also examine the cerebellar signs in the upper limb, lower limb, and for weakness. So he said, yes, what are you looking for? And I said that. And they were okay with it. And they've given me full marks for neuro. So I think that's okay.
Thank you.
What was the
And
diagnosis, doctor, there in your neuro? What
I
cranial nerve
had
was?
a cerebellopontine angle lesion, CP angle.
So
So
anyone
the
has
patient does the patient has 5, 6, 7? Nerve palsy was there? 8?
Yes, 8, 7, 6, and also nystagmus, upper limbs. He said cerebellar sign is positive, but I didn't examine cerebellum. But when I asked for it later, he said it's positive. But I didn't have to show it or anything. The examiner told me that yes, it is positive.
Okay, so that is the unilateral CP angle lesion, right?
Yes.
Thank you so much.
The last question from my side to Dr. Nasim sir, as well as all the candidates who already passed, because we have been taught to manage the concern, including the disease name and the management plan, prognosis, as well as for the follow-up, okay, and including the admission needed or not. But I think it will take some times. Okay, so how can we manage it? Should we just mention the whole stuff, or just finish by saying, okay, this is the disease, medical condition we are planning to investigate and involving the multidisciplinary team, or just including the outcome, follow-up, as well as admission? Dr. Nasim, sir, can you just reply in this regard?
So, Dr. Islam, in my view, it depends upon the scenario. Few scenario, you need more time for explanation. Okay. So particularly suppose someone has addiction, so you have to give many lifestyle changes and advices also. So you have to keep the time for that. Okay. So it will depends upon the scenario, but in my view, don't prolong it. Just tell the symptoms you have. So suppose someone has a headache, so you will say the headache you have is most probably due to a condition. Suppose she has migraine, so you will tell that it's a classical migraine you have. Okay, and then you will define it in a layman term. Okay, the classical migraine, by classical migraine I mean is due to abnormal reaction of your blood channels to the different triggers. Okay, and that's why you have this headache. Okay, and what we are going to do now that we will run some basic test and then we will discuss our management plan. That's all. And then immediately you have to ask, do you have any further concern? Okay. I will.
Sir, can I add one thing?
Yes.
Yes, sure. Yeah.
Yeah, for example, if the patient is presented to you, for example, patient is having a case of when you're taking a long consultation station, patient is having shortness of breath. Okay, on examination you find this patient is having systemic sclerosis. Okay, so for that patient your diagnosis is interstitial lung disease. You can't say systemic sclerosis is your diagnosis. Okay, so it is a common mistake which was done by me also for many times when I was practicing. So one of the solution which I got for this is, before telling anything to the patient, just repeat the chief complaint which was there. Like, you have presented here with shortness of breath. I have taken the history and examined you. After the examining you, I am came to the conclusion that you are suffering from a condition in medical term we call as interstitial lung disease. Please don't bother about the term. Then they explain that thing in a layman words, and lastly say it could be indirectly associated with other condition which in medical term we call as cystic sclerosis. So that will complete your answer. Because if you say cystic sclerosis directly, it is not a proper answer for that question.
Yes, and we are thinking that we have addressed the concern very
Exactly.
well.
You have not addressed the concern.
And why the examiner has not given me good marks in the concern. Okay, the reason behind the Nigar has told us. Okay, so this is a very common mistake. Same like acromegaly with headache. Okay, so we are telling that, or carpal tunnel hand pain. So the we usually get once we will see acromegaly, we will think of acromegaly. The headache you have is due to acromegaly, or the hand pain you have is due to a condition called acromegaly. So you have to tell the cause the way the Nigar is telling. Okay, and don't mention in my view admission unless until you are 100% sure about it. Okay, so there are the few scenarios that required admission definitely, so you can be better to mention it. If you are not sure, don't mention it. Just tell we will run some test, a scan if required, and we will discuss our further management plan. Better to not to land in trouble by yourself. Okay, and cut it short, don't prolong it, and ask, do you have any further concern? So usually they will have 3 concern minimum. So after addressing the concern, still you have time, you have full time, you can explain everything about the condition. There is nothing like that. Okay? Till the examiner will tell you time finish, in my view. Doctor.
Okay, thank you.
I think Nigar has told much better way. Okay.
And one thing, doctor, actually some doctor has asked in between regarding that 6 minute and 7 minute, you know. So for that, what you can do when you're discussing with your partners, it is really important to discuss cases with your partners. That is important first thing. Okay, so what you can do, you can time yourself also. When the other person is timing you, that's fair, but you also time yourself and you make sure at what point you're turning from history to the examination. That will give you your judgment, like how much time you are requiring. Then you have to work on it, and subsequently you will come to know approximately, okay, this is my normal time by which I complete the history. This is not getting completed, that means the time is going away. Obviously you'll not be able to get exact is it 6 minutes or 7 minutes, but you'll be having some idea, okay, it is getting delayed, I should go to for the examination now. So that will give you a bit idea of it. Yeah.
Okay.
So anyone has any question? I think other doctors, we don't have much time left. Okay, so talk to them. Dr. Jawahar, Dr. Amir Ali. Okay, I think Dr. Amir is not joined because he initially did not get space to enter into the session. Okay, and Dr. Muhammad Abdul Ghadir also not got the space to enter into the session. Okay, so they texted me that they are unable to join initially. Okay, so from the next time we will try our best to increase the participant numbers. Okay, so this problem will not happen again. So thank you so much everyone for joining our session today. I think it's late now. So we'll try to do a consultation station day after tomorrow, I think, if I will get time. So thank you so much, Dr. Sophia, Dr. Nigar, Dr. Jennifer, and all of you, okay, for joining our session today. And I want to wish you, I want to wish you all of you best of luck for your future.
Sure. Thank you, sir.
Okay, thank you. So I will end our session today.